Good evening, everybody. Welcome to this special webinar that we have for you tonight. Hopefully you're doing well. Hope you've had a good day. I know a lot of you guys are very busy at the moment in terms of clinical work, whatever specialty you're currently working in, whether it's general practice or whether you're on the wards at the moment. But welcome to all of you who are back and you've been with us before, and welcome to lots of new names. I saw a lot of new names sign up today. We have around 340 signups, so we're going to give people a few minutes just to get on board. For a lot of you, it's your first time on the webinar, but please do let me know if you can hear me. Just give me some yeses in the comments. Fantastic, some messages coming in. I can see some names that I recognize, see some new names as well. Let me know if this is your first ever Arora webinar, guys. Let us know if this is the first time you're on with us. And also let me know whereabouts you are based at the moment. Let's see geographically where you're all spread. I'm just going to on my cam. Okay, so we've got a lot of spread of people right here. Durham, Newcastle, London, Birmingham, Sheffield, Essex, UAE, fantastic. Delhi, fantastic. So we've got some international people on board as well. And what grade are you guys? A lot of ST3s, people are mentioning ST2s. Excellent. Scotland, Cardiff, Wales again. Where else? Got London, Solihull, Bradford, Leeds, Edinburgh. Amazing, really good spread. So thank you guys for joining us, and hopefully you're going to find this of some value. I'm sure you're going to find this of some value. Remote consulting is an area that I'm getting a lot of questions about from GP trainees and also people who are due to start GP training. We've got a lot of you who are due to start GP ST1 pretty soon, and I know it's a brand new world, and I'm sure we'll be going through a lot of those common queries as we go through today. Thank you for all of you who are saying hello still. Leicester, Kettering, Southampton, London again, Birmingham, Sheffield, Leeds again, a couple from Newcastle again. Fantastic. Again, really good spread. I'm just giving people a few more minutes just to get on board. Once again, a lot of you are new to us, so I just want to make sure that as many people join as we can. We're really lucky tonight. We've got a super guest on, Rob Hendry from Medical Protection, who's going to share his knowledge and expertise in the field of remote consulting. So a couple of you are saying that you can't hear me, but I guess most of you can because you're responding to me. So I guess if you can't hear me, I'll put a chat, a log off and log back in, because sometimes that can make a big difference. Good, just give me some yeses, guys, if you can hear me, just so I know that I haven't lost you all and that some of you are still there. Just give me some yeses, guys, if you can. Yeah, good, lots of yeses flying in. Fantastic, so we're up to about 110 in at the moment. I think we should probably start. I know we've got quite a lot to cover again, and hopefully we're going to be quite interactive. So we're going to have a brief talk at the beginning from Rob, and then hopefully we're going to jump straight into your questions, because I know there are a lot of questions when it comes to this topic. So like I said, a brief introduction by myself. The main presentation of the webinar is going to follow. We're going to have Q&As, and then as always, we have offers for our webinar attendees tonight, and I'll go through those in a second. So a quick intro for Rob Hendry. Some of you guys would have heard this name before. I'm sure you have. Medical Director at Medical Protection. Really lucky to have him on board tonight for him to share his experience and expertise. Studied medicine at University of Dundee. Used to be a GP partner in a teaching practice in Dundee for well over 12 years. Did lots of work, as you can imagine, around medical law, medical ethics, and has been a medical legal advisor for a number of years, and has gained lots of experience in this field, as you no doubt will hear in a short while. As a foundation fellow of the Faculty of Forensic and Legal Medicine, and he initially set up the MPS Edinburgh office way back in 2009, and has climbed up the ranks to now be medical director since 2013. I'm sure you'll hear a little bit more about his story going forward. For those of you guys who are the first time on one of our webinars, my name is Dr. Aman Arora. I run Arora Medical Education with my wife Pooja. A lot of you guys, we're grateful that you followed us on our webinars for a number of years now. I was a GP. I'm now full-time in medical education. My passion is to help doctors get through not only just get through their medical exams, but to really maximize their careers. And that's why we do these types of webinars, try and fill in the gaps that people don't often talk about. There's lots out there about exams, but not much about daily consulting. So hopefully this will go a little bit of a way to help. Previous roles, lots of education-based roles. I used to be a PD in a GP training scheme in the West Midlands, used to appraise GPs, and used to be involved quite a lot in the GP recruitment area as well as being examiner for the GMC. So lots of different education roles, but my main role now is running Arora Medical Education, and that's how a lot of you guys have known us through the years, whether it's med school or PLAB or getting into GP or specialty training as well as MRCGP and post-CCT as well. So welcome to anybody who hasn't come across this before. Hopefully this is not the last webinar that you'll be on with us for. And as always in our webinars, we always have offers. We weren't planning to do one for this one, but whenever we do launch an offer, a webinar, people ask us what's on the webinar today. So we have 4 things available: 15% off our AKT online course bundle, our RCA bundle, our GPST1 trainee max for new GP trainees, and our post-CCT course for newly qualified GPs. I'll go through these a little bit more later on in the webinar, and the coupon will be coming up just before the Q&A later on. So we're going to jump into a couple of polls before we hand over to Rob. So I'm just going to launch the first poll now just to see whereabouts you guys are in your training. So you should see a poll come up right now. Please do click something, jot something on your screen just so we can see the spread of attendees tonight. Thank you to everybody who's done it so far. So 75% of you, so 3/4 of you, are current GP trainees, which is great. Some of you guys are thinking about GP training at some point in the future, and we've got some GPs on board, which is great. So 12% in their first 5 years, and 3% who've been a GP for 3 years or more. So a good range, actually, of people on board. So it's great to see you guys all attending. I'm just going to launch the second poll. How are you guys feeling currently about consulting remotely? Let's get some ideas about where you guys are in your remote consulting journeys right now. Some of you may not have done it, of course. So the majority, 38%, getting used to it, but looking forward to doing less. Some of you are very comfortable. About a fifth of you are very comfortable by now, and I guess we've been doing this for quite a while now, so I can see why there'd be a couple of you who are in this bracket. Some of you not very comfortable, some of you dislike it, and what about a quarter of you have not done it before? So hopefully this is going to add some value if you've never done remote consulting in its various forms. And the last poll before we get going properly, I think we're up to quite a few people on board now. So one last click if we can, guys. Looking into the future, what are your views on how general practice will be in relation to remote consulting? Let's get some. So 5% think they'll go back to how things were before the pandemic. 20% think there'll be a slight increase in remote consulting, but back to face-to-face. Mainly, about half of you think this has significantly shifted the way that we're going to be consulting in the future. And about a quarter of you think that general practice will change even more in the next 5 years when it comes to remote consulting. There's some interesting views there, and it'll be good to see what you guys think at the end of this webinar in terms of how these views change. So just let's get some interaction, guys. Give me one word. If you're a GP trainee, and I know most of you are a GP trainee right now, how have you found remote consulting so far? In one word, let's hear where the general feel is in terms of remote consulting. Let's give me some ideas. Worrying, anxiety-provoking, stressful, difficult, new, exhausting, daunting. Hopefully Rob will be listening to some of these words. Challenging, stressful, new, patient-friendly, good, enjoying it, risky. I'm sure we're going to talk about risk quite a bit in this webinar. Convenient, ambiguous, difficult, challenging, stressful, anxiety-provoking, again, isolating, that's an interesting one, enjoying it, good. So there's a huge range, actually. And the feel that's coming through is, as with anything new, I guess, particularly when it's patient-related, worrying, anxiety-provoking. But a lot of you seem to be enjoying it. I wonder if you've been doing it for a little bit of time, because that's the story that we tend to get. Good. So it's great to see the vibe that we have on at the moment. In GP training, where does this all fit in then? So, of course, in GP training, telephone versus online consulting, I'm sure we'll have a bit of a breakdown of the pros and cons and the challenges for both of these. But I do get content a lot by GP training saying they're really struggling with all-day telephone consults or all-day online consulting, very different skills to face-to-face. And that's something I often get contacted. There's lots of concerns coming through to me about GP training and remote consulting. A lot of you guys, particularly ST1s, ST2s, it's hard enough you guys going into general practice jobs as it is. You may not have done much general practice in medical school or in your foundation year, so it's hard to move into that general practice style of thinking. And now on top of that, you've got to suddenly add in this remote consulting feature as well, which can be quite challenging. I can see why it is quite stressful. A lot of questions come to me in terms of examination challenges, of course. How do you do an appropriate examination over the phone or online, and how do we change it to face-to-face? When should we do that? What's enough in terms of examining online? I'm sure we'll touch on some of these things in the webinar today. And of course, implications for your exams. The RCA, some of you guys might be praying for this right now, of course, the temporary replacement for the CSA exam. And some of you guys who are recording consultations for the RCA, the recorded consultation assessment, the second part of MRCGP, are doing it purely based on telephone consults and you're being recorded on these, or based on video consults. And again, people are very worried about that because you haven't had much experience. And maybe even when we go back to CSA, of course, this is a temporary exam that the RCGP are using. When we go back to CSA, which is traditionally face-to-face, OSCE style exams, maybe there's going to be some more video consults and telephone consults in there based on the way that general practice is changing. So lots of implications when it comes to GP training in terms of remote consulting, and we'll touch on some of these as we go forward. Right, so without further ado, I want to introduce our special guest, Rob Hendry. Rob, if I'm going to try and get you on board, let me see if I can get you to share your screen.
Good evening, and thanks very much to Aman and Pooja for asking me along this evening to join you in what I hope is going to be quite an interactive session. And thanks to Aman for my introduction. As he was saying, my own background is in general practice, so I've got a particular interest in the way general practice has been developing and changing, particularly under the pressures of the pandemic. At MPS, I've got the joy really of working with doctors around the world, and really one of the various things I've found is just how the pandemic has driven the increased use of technologies, and interesting to see how doctors in different countries have been dealing with that. I was particularly interested, somebody's joining us tonight from Delhi, been speaking to some colleagues in India, and it really is extraordinary how their technology is really leaping ahead as a way of delivering care in new and novel ways. And in other countries like South Africa, Ireland, Hong Kong, and so forth, as well as the UK, I've been speaking to people. So what I thought I would do tonight really was to give you a quick sort of overview of what I see going on, I suppose with telemedicine generally, but really focusing down on remote consulting, because I should imagine for most of you that's the key issue at the moment. And thinking about, you know, going about how one goes about conducting consultations remotely, what some of the issues there are, what some of the regulators and so forth are saying, and then maybe look at some practical tips for reducing your risks in that space. I'm going to leave plenty of time for discussion because I'd be really interested to get your impression of what's going on, what your concerns are, and so forth. So I think the idea is if you would type your questions in, Aman will be able to monitor those as I'm chatting, and then we can pick up on those when I've finished the kind of more formal presentation part of this. So, I mean, you don't need me to tell you that the pace of change has increased with the pandemic. It was suddenly really, I think, for those of us who were in practice at that time last March, where suddenly overnight patients were being told you can't come to the surgery, you've got to consult remotely, and you know, the health minister saying that all consultations should be done this way and whatnot. Really big moment, big sort of watershed, if you like, in the way we go about interacting with patients. And that picks up, I suppose, some of the changes we're already starting to see in what is broadly referred to as telemedicine, telehealth. These, oops, sorry, these, I've go back the way. Yeah, these sort of terminology, I think, are knocked about quite widely, meaning different things sometimes to different people. But when we're talking about telemedicine here, I suppose the commonest way technology would be using to consult with patients remotely is on the telephone. And I'd be interested later to get a feel for how much of your consultations are being done on telephone as opposed to video or internet-based virtual consults, which I think are being increasingly offered. A lot of people are producing platforms for doing remote consulting, and we can perhaps compare and contrast those two. Of course, there's also the issue of changing how you prescribe. We're also talking about electronic prescribing, and certainly in some countries, in some areas, that seems to be more problematic than others, but it changes, I think, the way some of that is being done and the way we work with pharmacists and so forth. Other specialties like radiology have been doing telemedicine for a long time. We know that you know, a lot of radiology, even in the NHS in the UK, is now being reported outside the country. by others. And I think radiology lends itself to that because you can move images around digitally very easily. But I suspect we'll see more of that. I know some of our dermatological colleagues are doing so. And again, I think Matt Hancock at one stage suggested that perhaps the answer for the crisis in general practice in the UK was to have doctors doing remote prescribing, remote consulting from, I think it was Lithuania or somewhere. So it may well be that this cross-border work will increase. Telemonitoring, again, interested to know if any of you are using this with patients, but there's no doubt for some long-term conditions like diabetes and so forth, wearing wearable technologies which allow you to monitor blood sugar, patients checking their own blood pressures and so forth, allow people to interact and exchange biometric data with their physicians remotely, and that can lessen the need for face-to-face consultations. And some of the early evidence coming back is that particularly some of the younger diabetics prefer that way of working. They hate going to diabetic clinics if they can monitor things remotely and interact either with a specialist nurse, a GP or whatever, or perhaps increasingly with bots who can give them advice about insulin regimes and so forth. Another area I've been speaking to people about, interestingly, is in psychology, psychiatry, and speaking recently to child adolescent psychiatrists, who they're finding that a lot of youngsters much prefer interacting with mental health teams remotely from the privacy of their own bedrooms rather than having to go and sit in outpatient clinics where they feel stigmatized or perhaps identifiable. And then, of course, there's the whole issue of MDT meetings, teaching, and in the hospital's ward rounds. But again, I suppose a lot of GP trainers and trainees are having to interact remotely, and it's interesting to see how that's working and what the challenges there are. And of course, I think as GPs, we were used to doing this earlier than perhaps some of our hospital colleagues, but it's extraordinary the wide range of specialties that now taking this up. I mean, orthopedic surgeons are now doing fracture clinics remotely, and a number of clinics for the chronic sort of conditions like rheumatology and whatnot are finding actually this is a much better way of interacting with their patients. Patients perhaps crippled with rheumatoid don't particularly like having to trail up to hospital. Outpatients sit there for ages to see a doctor they don't really know, whereas they can consult perhaps with a consultant they've known for years remotely, and it's a more satisfactory experience for everyone. So things are moving at some pace. I'm not going to go through all of these predictions individually, but this was some work done by the Oliver Wyman Group. They're a large management consultancy who were looking at how they predict some of these changes will look after the pandemic. And why is that important? I think it's of significance because there's a huge amount of private money, investment money going into telehealth, telecare, whether it's investors putting money into e-consulting platforms or other opportunities. I saw somewhere recently they're talking about a digital hospital. I'm not quite sure how that works, but there's a lot of, as I say, a lot of venture capital, private equity monies going into these technologies, whether it's hardware, software. So there's no doubt, I think that will drive some of the innovation that you guys will get caught up with as you go on through your careers. So it will be interesting to see if it changes how you consult. I know in some places already some GPs are doing group consultations. Say for a diabetic clinic, you might have half a dozen or more diabetic patients on a Zoom call, and you can give general advice or talk about aspects of their healthcare in that way. And it really changes, I think, the traditional model of in-surgery one-to-one consulting. And the question again is this how health education is going to be delivered? and will it change the nature of the job of general practice? Lots of people give us advice about how to do it safely. The General Medical Council, and it's usually worthwhile acquainting yourself with what the General Medical Council's guidance is, because ultimately they will be the ones who take you or make a decision about whether what you've done is reasonable or not. And these are the key principles they set out. They've also got, if you go onto their website, they've got a little flow chart, which you won't be able to read there, but it is worthwhile having a look at that, perhaps, and acquainting yourself with that, particularly if this is an area, I suppose, that's going to be discussed in membership exams and so forth. But the key areas, and we'll pick up on this a little bit more as we go on, but the key areas they identify is that patient safety is the priority. So they say it's really important that both you and the patient can identify who each other is and verify that you are who you believe they are. There's quite a lot of concern about vulnerable patients and safeguarding issues here. And that's, I suppose, one of the areas of concern perhaps with childcare or vulnerable young adults or vulnerable adults of any age, and whether they can be adequately protected in this situation. We might pick up on that again a bit as well. So that they say you have to identify yourself. Explaining how it works, explaining why you're consulting in this way, I think is important. And one of the questions I often get is around issues of consent and what do we mean by that? What consent is required if you're doing a remote consultation? And we'll pick up there. Ensuring that you've got safe alternatives, or that the consultation or the treatment management plan you put in place is safe is important. As I say, we'll talk about consent. We'll talk a little bit more about records, but it wouldn't be a medical protection discussion if we didn't talk about the importance of record keeping. And we'll say a little bit about video, either recording on video or audio of the consultation, because I suppose that becomes part of the medical record. And that could be helpful. But again, people are often anxious about patients recording video consultations and whatnot. We'll say a bit more about making sure that there's adequate safety netting and the options, making sure that the options you've decided on are safe. And that includes obviously doing nothing. And then they talk about maintaining your competence in this area. And I think particularly for those of you who are about to go into training in general practice, it's important that you do have adequate training and you feel comfortable with the support you're getting there, because I think many of us have gone a bit of a crash course for how to do remote consulting. Other people getting in on the act about some of the information governance aspects of remote consulting. In England, NHSX, who are the sort of digital wing of the NHS, are producing a lot of advice in this sphere, and same as they have their equivalents in Scotland and Wales. There have been some concerns about what platforms you use for communicating with colleagues, particularly around, can we be WhatsApping my trainer? Can I use, other social media platforms to get a bit of advice? And I think there's often concerns there about sharing potentially confidential patient information. And I suspect that as we go forward, there will be more approved platforms available. There's no doubt NHSX, and I think the Department of Health, are encouraging the use of video consultations. And again, there's a number of those becoming available. And I know in Scotland that we have a specific dedicated platform that some of you might be using. And this whole issue of secure access is important. And there's a lot of advice out there. I'm not a technical expert, but we get a lot of questions from people saying, is this something that we should worry about? Where do you go for advice? And I would point you towards the NHSX or the equivalent websites. And of course, if you are using your own devices as opposed to either one supplied by the practice or by the health service, you have to be pretty careful that you've got adequate encryption and so forth. And I think there's been some changes recently to WhatsApp that have given rise to some concerns for people. And of course, you know, all of you, or I would have thought, would be working within an NHS setting. But if you're not, and if you're working for some private companies providing online servicing and things, it's really important that you are aware of any policies and protocols they have in place and that you comply with them. And just a web address there. So when it comes to the practical issue of thinking about, you know, am I comfortable getting going with this remote consultation? The things I would suggest you should be bearing in mind and thinking about in deciding is it safe to proceed is, firstly, can you identify the patient? Do you know who it is you're seeing? Are you comfortable with that? And equally, are they able to identify you and know what's going on there? Because I think if you don't have that basic starting point, one would have some difficulties. Secondly, do you have the medical records available to you? Now, I should imagine in the normal GP setting, that should be possible, and you can have a platform or that either links with the records that you can have access to them. But I think the time that the risks start to increase is if you don't have access to the records to know the patient's history, drug histories, and so forth. Then consent comes up. Are you and is the patient happy to proceed? A lot of people say that the patient, simply by logging on and getting involved in a remote consultation or taking part in a phone consultation, is implying consent. And that's probably true, but I think our advice is that it's worthwhile just at the start of the consultation having a brief discussion with the patient to say, look, this is how we're planning to run the consult today. This is why we're doing it. Now, whether that's because you in the current climate, you don't want people coming unnecessarily to the surgery, whether it's because you feel, you know, for this individual patient, it's the best way. But making sure that they're comfortable with it and that explaining there that there may be occasions or maybe reasons that you have to move to a face-to-face if, for example, an examination is necessary or whatnot. And I think it's worthwhile just making a very brief note to say you've discussed it and that the patient's happy to proceed. Again, making sure that you're comfortable that the systems you use are secure and that the system's appropriate and technically sound. I mean, there's nothing worse than if if the internet keeps dropping, if the sound's breaking up, whether that's with you or with the patient. So making sure that you are in a position where the medium is working and that both sides can actually hear and understand what's being said. And all of this, I think, was really quite neatly encapsulated by the so-called 6 C's. I wish I could claim ownership of this, but in fact, it was some advice given out by the Royal College of Psychiatrists. And as I mentioned earlier, actually, psychiatry are using a lot of remote consulting. But they talk about in their publication, and they talk about the 6 C's being competence. Are you competent to use the platform? And particularly, is the patient competent, or do they need some assistance? The whole issue of actual digital poverty is one that does cause a lot of concern to doctors. But there's that, apart from being able to get access to secure and effective online platforms, there is the question of, does the patient know how to use it? Can they or do they require some assistance? Communication is a big issue. You will do a lot of training, a lot of discussion in your training year around consulting with patients and the importance of non-verbal communication and so forth. And obviously on a platform like this, You have to moderate your speed of language. Whole issue of eye contact, and I'm very conscious I'm probably not giving you eye contact because I'm looking down at the screen rather than at the camera, but that can be quite disconcerting for patients. Making sure that there's adequate lighting and that the sound works. And again, if people have got disabilities, whether it's deafness or whatever, are they actually able to communicate in a way that you would in the surgery setting? Next thing they talk about is contingency, and I think that's really important. It's having a contingency plan in place if things aren't going well, either if the technology collapses, what are you going to do? Or if the consultation isn't going well because you're worried that you're really not able to ensure that the patient's safe or that there isn't something more going on in the background. Or if the patient needs an examination, what are your plans? So rather than having to make it up at the time when there's a problem, much better that you've set up a contingency plan in advance of any remote consulting session. Fourth C is confidentiality. We've talked a lot about that, but it is important that you're confident that the position is, or the situation, both for you and the patient, is confidential. I'm speaking to you tonight from my study, but I live in an open plan kind of house. And if I was consulting, am I happy that, you know, perhaps my family are walking about in the background or whatever? And the same for the patient. We mentioned this issue of digital poverty, and for, you know, in the old days, a lot of people who were less well off would access the internet and things in their local libraries. And I know local libraries are shut just now, but you know, was that an appropriate setting to consult in? And indeed, we had one story I'd heard of somebody trying to have a consult with a patient who was in the upstairs of a bus, and you can imagine that probably doesn't satisfy the confidentiality issues for most patients. Next was consent. We've talked about that, and we may want to pick up that in the discussion a bit later, but I think it is important that the patient understands why you're consulting in this way and what any limitations are. And then the last C is confidence. Confidence both in the technology and in your ability to use it, but also in the assessment that you've made. Are you happy at the end of the consultation? Are you confident that you've reached a reasonable diagnosis, a reasonable plan, and that you feel it's safe to move on? And I think that's something, particularly for those of you who are going into training or thinking about early aspects of this, it's making sure that you develop that confidence and that your trainers can support you in that sort of holistic confidence when you're doing a consultation in a way that you wouldn't have traditionally been trained to do so. So why would you want to convert to face-to-face or indeed defer the consultation? Because I think one thing that people sometimes find difficult is to say, look, this isn't working or today's not appropriate, let's defer this to another occasion. But you may want to convert to a face-to-face. And the sorts of things one would worry about is if you don't know who the patient is, you've no access to records, there's been no referral, why is this person suddenly tuning in? And I think again, one's concerns might go up if it was a consultation in which they were perhaps looking for, you know, drugs of potential abuse, opiates, things like this. You think, I would be very uncomfortable about it. Same with safeguarding issues. If you're anxious that the person you're speaking with might be vulnerable. And one of the things I heard reported quite a bit is the concern that you're never quite sure who's in the room with a patient, in the same way as you are obviously in the surgery, where you can have much more control of what's going on. So if it was, I don't know, but a teenage girl perhaps looking for advice on pregnancy related things or contraception or whatever, are you comfortable that what she's asking is really what she wants to talk about, or is there perhaps people in the room putting pressure on her and so forth? In a situation like that, you may wish to convert. Obviously, if a clinical examination is required, now I know that a lot of physios and others do remote consults and will get patients to do joint movements and things. So I suppose a degree of examination is appropriate. But when I was hearing stories of people asking patients to palpate their own abdomens, to find tender points. I felt very uncomfortable with that, and I'd be interested in your thoughts there. And clearly, as we've said, if there's technical limitations, if you simply can't hear what's going on, if the whole thing's starting to break up, you probably want to get the patient in. And if you are worried about security and confidentiality, that would be another reason. Conscious that we're nearly through this bit, but just to stress and underscore again the importance of record keeping. We do in medicine like our little acronyms, and we came up with this one, ECHOS. And this is perhaps give you a little bit of a structure for how you might keep a record of a remote consultation. So E for the environment, what's the context? Why are you doing it in this way? And a little bit about, that, because we know that the GMC have said that should there be a complaint in the years to come about the way you consulted during the pandemic, they will take that into account. If somebody says that you didn't do it properly. But will we all remember, it's all very clear in our minds now, but will we all remember the context that some of the care we've been having to give at this time when things either go back to some degree of normality or move on to a new normal? So getting the context is important. Then consent, I think it is worthwhile making a note just to say that you've discussed this with the patient and that they're comfortable to proceed. Then a history and assessment as you would normally. Probably even more important, take a very accurate, detailed history when you're not able to pick up on some of the subtle clinical signs that you might see if a patient was sitting in front of you. And then setting out your options based on what you've gathered, what your formulation of the situation is, and looking at what options there are, whether that's for treatment, for follow-up, for investigation, or whatever. And then engage, well, again, this is really this idea of having some contingency to engage any protocols the practice has or that you have in place should they be necessary. And then finally, safety netting. And I suppose in practice we do that all the time, but I think ever more important if you've not got the patient in front of you and you're anxious that you may have missed some subtle signs, making sure there's a very clear safety netting plan in place to catch patients who don't, and whose illness or whose problems don't develop in the way that you and they are predicting. And really just before we get into the chat, just to think about how is this all going to develop in the future. And it was interesting that a number of people thought general practice is going to change. And I think that might be right. It may well look very different in years to come. I think as GPs, we've always been quite entrepreneurial, been quick to pick up on new technology, quick to exploit some of their potentials. So I do wonder if we're only just starting to see the start of a bit of a revolution with the use of technology in primary care. Training, I think, is going to be really important. There isn't much training, either it's undergraduate, postgraduate level for how you consult remotely traditionally. Perhaps that's an opportunity for Aman and his training company to think about. But I think as we get up to speed with this, people will be better at understanding what skills you need for the communication and so forth, and honing that to the virtual or remote platform. I also think it's an area where we as GPs can help some of our colleagues in other specialties, because as I say, I think we've had more experience of this over the years and the way we think about long-term relationships with patients. We may have something to contribute to the training of the wider medical profession. I suspect there will be some regulation. I think the regulators, the GMC, CQC and others are just starting to try to tackle the issue of what are the reasonable standards in this area. And nowhere is that more so important than some of the cross-border issues. Because one of the things we've seen with the pandemic, we've had doctors who get stuck overseas wanting to consult back in the UK. We've had patients stuck overseas wanting to consult with their doctors here. As I say, suggestions that perhaps you could buy in medical services from other countries And as I say, we know already in some specialties that's happening. And really the regulators and the regulations for licensing and in which countries you can be practicing were never designed with any of this in mind, and are causing some difficulties for doctors in those areas. And again, finally, I think we'll see the emergence of some new specialist services because there is so much investment going into the hardware, the software of this. I mean, goodness me, I remember when I was in practice, pulse oximeters were, things that we were very excited about having, but patients now with chronic lung disease can buy a pulse oximeter off Amazon for what, $9.99 or something. I think we'll see more in-home patient-led biometric monitoring, and that's going to present something of a challenge to GPs about how do you interpret the data, how do you help and support patients manage their chronic conditions when they're taking on some of these roles with technology. So really that was all I was going to talk about just now. And if you want to, if I can stop sharing my screen, Aman, perhaps we can move to take some questions and have some discussion.
Yeah, fantastic. Thank you. That was really helpful, short, sharp, to the point, and some really good takeaway points, actually. So let's just see if we can get our screen back on. I just wanted to introduce Pooja as well, guys. She couldn't quite make the beginning. She's putting our little one to sleep, but Pooja is here. Pooja, do you want to say a couple of words before we jump into the questions?
Hi, evening everyone. Thank you, Rob, for a brilliant presentation. Lots of food for thought there, especially for those of us working in general practice or about to enter general practice. We've got lots of questions based on your presentation, so I think it's best to get going with those questions, if that's okay, Rob.
Sure.
Pooja, just before we go ahead, I just want to get a quick feel from the audience before we go into the questions, guys. What did you think? Was that helpful? Was that of some value? Let us know. And a few of you asked about the code as well, so I'll give you that in a second before we go into questions. But how did you find that? Let's just get some feedback on thoughts. Good, lots of good comments coming in. Very helpful, useful, eye-opener. Gave me some confidence, helpful, lovely presentation, very good overall, helpful. Thank you, Rob. Useful, helpful. Great. So some really good feedback actually, Rob, which is great to see.
Yeah, a little embarrassing if they'd all gone, what a load of rubbish, but
but it just shows it's an area that I think the more information that we can get, the better, because it's a brand new area of medicine for a lot of people, and like we heard at the beginning, people have lots of doubts and fears and worries about it, and I can see that this is going to be really helpful just from a practical point of view tips. So we are going to get into questions, guys, but a lot of you are asking for the coupon. So I'm just going to give you that coupon first. So the coupon to use is Arora Webinar 15, Arora Webinar 15 for the 4 different online courses that we have. And this coupon is going to be valid until midnight, but there are 10 coupons available for each. So we have our AKT Triple Pack, which is a 13-hour online course for clinical stats and admin for the AKT exam. We have our RCA 90 online course, and this bases and features a lot of consultations that you guys are doing on telephones and video. So 15% off that one. GPST1 Trainee Max is for all of those doctors who are about to start GP training or GPST1s, and it covers everything that you need to know as a GPST, and then also our post CCT Max as well course. So for those guys who are about to come to the end of ST3, or if you're a new GP, everything you need to think about that perhaps you didn't get taught in your GP training years because you're focusing on exams, we cover it all here. So the coupon, just to remind us, Arora Webinar 15. So that's going to be valid until midnight tonight. Right, so sorry, Pooja, do you want to jump back in and we'll start going through some of these questions because there are quite a few that have come in.
So Rob, the first question that's come in is really from the other side, that they've asked, they're currently working in acute medicine in secondary care, and they've mentioned we take the referrals as an SHO, but seem to be getting a lot of referrals from GPs with query, for example, DVT, and they're just wondering what the implications are, because often the case is that the GP has not actually seen or examined the patient in person, and they're just going off the patient's description in order to refer the patient in. So what are the implications there?
Yeah, I mean, I think that's a really good example, I suppose, of this issue of how primary and secondary care work together. And one of the things I think is a shame is if, you know, there's been that sort of drift between primary care physicians and the secondary care as it became a bit less in touch with each other. Things like this, I think that would be an example of where having some sort of contingency, either with and having some conversations with your local physicians or whoever would normally take a DVT referral, with having having something of a discussion in advance about what would we do, because I mean, I know that the clinical assessment of potential DVTs has kind of changed over the years. What should you be suspicious of? When should you be sending people up, either for investigation, blood tests, and so forth? And I think if there is a change, because again, I think, you know, and what I'm just wondering here, and this is where I would defer to those of you who are more clinically up to date than I am, if somebody had a good history of, you know, a red swollen calf, how much actually seeing it, would that make a difference about, you know, I'm just trying to think what your clinical examination would add that might change your referral decision. Now, I mean, I hesitate to give clinical advice, maybe we're just in Pooja and Anand's take there, but, you know, if somebody gave you a good history, you could, you know, you see it's obviously swollen, would you really need, you know, would a clinical examination add a great deal? I don't know. But I think and I'm trying to think of some other examples, but I think if there are things where the GP's normal clinical assessment would make a difference in an acute situation, and that's not possible, it would be worthwhile having almost a protocol, if you like, put in place, rather than it ending up with some poor SHO or registrar having an arguing the toss about a referral, which doesn't do either the GP or the hospital doctor any good, or indeed the patient.
Yeah, I think that's a really good point, and it often comes down to, I guess, in general practice and in training in general, if you're going to do an intervention, how much is it going to change your management? So whether it's doing an investigation if they're in front of you, or bringing them in to do a physical examination, how is it going to impact things? And if it's not going to impact it, then can you save patient time and etc. And make a decision?
Yeah, and to widen that out a little bit, two things I would say. One of the positive things I think of the pandemic is that, and again, we're interested in the clinicians' comments here, but I certainly anecdotally think there's been more conversations between GPs and specialists to discuss patients and take advice than there used to be, because I think it was, you know, the pattern we'd got into was that you just referred, whereas now you can pick up the phone and have a chat and say, look, does this patient need seen? Or whatever. And the other thing, again, I was talking to a cardiologist, and they've changed their approach very much in that they will speak to the GPs and then arrange investigations like echoes and whatnot prior to seeing the patient in the clinic, which actually probably is a better pathway rather than the old days where you got a referral letter, they saw them and went, oh yeah, you're going to need an echo and and you know, and then come back for another appointment. So I do wonder, and this is where I say, I think there could be some silver linings here to actually get closer working between primary and secondary care, to, you know, because we've been doing, you know, the way we worked hasn't changed much in 40 odd years, 40, 50 years. Could this drive better patient pathways and better interfaces?
Yeah, well, let's get some feedback from everybody, guys. If you have any thoughts on that and what you found yourselves in terms of how you're communicating differently pre-pandemic and now with secondary care, it'd be great to hear some of your thoughts as we move through some of the other questions. But a great question to kick off. I've had another one that's coming up saying, I referred several complex neurological cases to secondary care. Patients and myself ended up unsatisfied with the remote consulting process. Is this a justifiable thing, I guess, for a patient and a clinician point of view?
Yeah, were they dissatisfied with, because they got a remote consult with the neurologist? Was that the
Not sure.
sense, or Yeah, I mean, yes, I mean, I can see that. I mean, I think remote consulting can be useful, but it's not some sort of panacea or catch-all, is it? And I know, again, I know from speaking to even just friends and family, they find it unsatisfactory if they've got not a life-threatening condition. I mean, again, just anecdotally, a friend of mine has got a knee problem. It sounds like he's done his cartilage, but he's had a remote consult who's been told it'll just be a bit of arthritis, take some painkillers. Now he's not going to get an MRI, he's not going to get an arthroscope probably anytime soon, but that's probably what he needs. So yes, I think there is a danger that now he's not going to die, he's not going to come into great harm, but it's a bit of substandard. And I think something like that is suffering. That's probably as much COVID as it is remote consulting.
Yeah, that's a very good point.
Sure. And I think following on from that, Rob, really, I think the next question, as you quite rightly mentioned in your presentation, touches upon digital poverty, especially in terms of, are we looking at digital health inequalities in regards to elderly patients who may not be tech savvy, or maybe are we being more favourable to millennial patients? But the question that's come in following on from that is, do you think telemedicine undermines the doctor-patient relationship that general practice has so heavily relied on over the years?
Yeah, well, there's a few interesting questions in there, because I think the digital poverty thing is really important. We did a survey of 1,250 GPs, or 1,250 doctors, and 83% of them said they were worried about vulnerable groups not getting access to healthcare. And we know already that the better educated, more articulate, more affluent part of the population already gets more than its fair share of healthcare, and it's even in primary care they access GP services much better than others, and I think there is a real risk of that widening if that isn't addressed somehow. So that's the first thing. Will it change the GP doctor-patient relationship? Yeah, I think the doctor-patient relationship probably is something that has evolved, and different doctors have different styles of consulting, different ways of relating to patients. And certainly things have changed from the kind of Dr. Finlay's casebook type of medicine, where the family doctor, delivered you in your house and, looked after you all the way through, and came and did house calls when your kids were ill and all the rest of it. So I think the relationship has been changing, and I think I think video consulting or remote consulting is probably more transactional. I think it seems to work better if both the patient and doctor, if it's a clear agenda of what they want out of it. So if I don't know, but if I've got a hernia and I'd like Aman to refer me to get my hernia fixed, that this is fine, it works well. I think if it's less well-defined problems, maybe if there's more complex social, psychological aspects to the problem, you lose that, and that may go. And I know, well, again, the research seems to be that some doctors really like consulting this way, others really don't like it, and I do wonder if that reflects the style of consulting the doctor likes to do. So the GPs who like to get to know the family and really are maybe better at the while I'm here type comments and things, I think my impression is that might be eroded by remote stuff, whereas the more transactional stuff, and certainly if you're busy, and a lot of people with chronic conditions, which I suppose increasingly are managed not by the GPs but by their staff. But if a patient's on long-term antihypertensives or something, they're busy, they're working a long way away from surgery, it's a lot easier to exchange biometric data, check, and get their prescriptions done remotely without coming in, because that sort of relationship may be more convenient. So I suppose, yeah, but I think, and again, be fascinated just by people's views of how general practice is evolving and how that relationship works.
Yeah, and it's only going to change further, isn't it? People's views are going to adapt as they get more used to it. But
yeah, so the next question, Rob. So yes, lots of comments coming in about those currently practicing. Lots of people saying that it really does vary from area to area. I know certainly locally, in regards to the DBT question, there is a local pathway, and based on the WELL score, you can refer to the community, and it may not necessarily reach secondary care. A lot of people saying that they are using advice and guidance more often and finding telemedicine useful. But moving on to the next question, an interesting question. As a shielding trainee working remotely, are there extra layers of protection against complaints?
Yes, interesting question, and I suppose there must be quite a few, both trainees and established GPs that are having to shield. And I suppose this would even underscore the importance of having a sort of contingency, a bit of a plan, so that if the consultation was going in a direction that you felt the patient needed to be seen, needed to be examined, or that was technically falling apart, it would be important that you had a system with either a colleague or with your trainer or whoever in place to allow that to convert easily, so that you weren't compromising either your ability to consult or the patient's care by the fact that you personally couldn't see them and that you would have to remain remote. Because if you're shielding, there would be no reason that you couldn't do normal stuff remotely. And I wouldn't think it was any business of anybody or the patient or anybody else your own condition. So, but having a clear pathway, whereas some other people might say, well, look, we'll defer it, so I'll see you tomorrow in this setting, or I'll do this. Actually having a clear plan to say, look, this, I think we're going to need to get you in, but my colleague Dr Arora will see you at such and such a venue at such and such a time, that sort of thing.
Yeah, really interesting actually, and there are quite a lot of trainees, as you say, who are shielding and obviously trying to record for the RCA assessment as well, and it can be it comes with quite some challenges, I'd say. I'm conscious of time because people need to jump off, but I reckon another 2 or 3 questions. I'm going to jump to the bottom. Pooja, if you carry on going from the top, and we'll try and cover as much ground as we can. So we've got a question saying, I'm a bit worried about patients potentially recording consultations. What are the legal implications of this?
Yeah, that's it. We get a lot of people asking about that. And in fact, it was always a concern about people coming into the surgery and covertly recording conversations. So paradoxically, I think the fact that we're talking here maybe video consults, and you're worried it ends up on YouTube or something. I think the fact, and I would include this as part of the introduction, the taking consent, I would have a conversation as to whether or not you or they are recording the consultation. So it's more explicit. And I think actually most platforms, a little light would come on, so you'd actually know the session was being recorded in a way that you wouldn't have done if somebody was using their home phone or had a tape recorder concealed about themselves. So I think having the conversation is good and established trust. Generally, and I know a lot of doctors are anxious about it, generally my experience has been when there have been recordings, 9 times out of 10 they're to the doctor's advantage. If there's ever a dispute about what was said, and I'm thinking here some of the work we would do with claims or complaints, particularly in an out-of-hours setting where patients phoned up for advice. An allegation often is the doctor refused to visit, refused to do something. Now, the patient may believe that's what was said because, as we know, people often don't fully recall consultation, especially if they're stressed and anxious or something has subsequently gone wrong. Almost invariably, when you listen back to the recordings, the doctor's recollection's right rather than the patient's. So I wouldn't be too worried. And I suppose the other thing to say there is that most doctors wouldn't consult in a way that they would be embarrassed about somebody hearing. But to put a slightly more positive spin on it, if it's a complicated consultation you're having, with a lot of information to disclose, or if it's somebody who may have some impairment of understanding or whatever, actually having a recording that they can go back and revise is probably a good thing. If they want to, share it with their family, if you're discussing, I don't know, management of a complicated thing. I know increasingly oncologists, I think, find it useful because we know the evidence, is that the minute you say to a patient something about cancer, they kind of stop listening. And, if you're then discussing alternatives for chemotherapy or whatever, much better, actually having a recording they can go to is helpful. So I do wonder, looking to the future, whether, and especially as GPs are left to manage more and more complex chronic and multiple comorbidities, actually having recordings of the consultations might be to everyone's benefit. So, but yeah, my advice would be have a word with the patient about it in advance.
I think lots of good points raised there, Rob. And moving on from managing lots of complex comorbidities, once again, another concern that's been highlighted is, has there been any discussion or thoughts on whether the teleconsult model still fits the 10-minute consultation recommendation? We've got an ST3 struggling with time management, and they find that they need to ask more questions just to get to the same starting point of where they possibly would have avoided those 10 questions initially just by basing how well the patient is by eyeing them as they walk through the door.
Yeah, I think a really good, well, both comment and question. And I think a lot of us would have some concerns about the 10-minute consultations anyway, as we're dealing with more and more complex stuff. Thinking back to my days when I would have been doing 10-minute consultations, you always hope there'd be some nice quick ones in between times that you could catch up, and that is less and less so. You don't need me to tell you that. I think trying to do consults in the old-fashioned way remotely isn't ideal. Apart from anything else, it's more tiring. You need to take breaks. You need to get gaps. I'm not conscious, but I'm sure there will be some work done on what's the most effective ways to structure consultations. The days where you would start a surgery and expect to see 18, 20 patients, and without a break, I don't think that's a very effective way of working. I would hesitate to suggest better ways, but I think your questioner is absolutely right. It's finding the most efficient, or the sort of optimum way of structuring the consultations over the course of a day, especially if you're not having the normal breaks of meeting your colleagues, having a coffee, speaking to the health visitor, spending some time in reception, then going out and doing a call or two. That if that working pattern has been completely turned on its head by COVID, then I think you need to look at the whole timing and approach to consulting.
Again, another evolving area. I'm sure that's going to change.
Yeah.
We go more and more into the teleconsult model, but we've had loads of questions in, but I think possibly one more, just because people are we've got things to do and work tomorrow. There's a good comment here, actually, I just wanted your thoughts on. I think one of the challenges is going to be with antibiotic stewardship. I think there's a much lower threshold for giving antibiotics to patient demand rather than when they're in front of you doing a thorough exam. Just interested whether you've come across that from maybe a complaint side of view, or any thoughts you have on it.
Yeah, no, I think you're right. There has been some stuff I've read that is saying that remote consulting and remote consult, whether it's consulting with a patient, whether it's speaking to a colleague, whatever, it works well when both sides are in agreement. But where it doesn't seem to work so well is if there's a tension, or if you're trying to persuade somebody in a different direction. So I think that comment is well made. And there are times where one has to be a little bit stricter than you would normally. So it's not just a question of saying yes to every patient demand. And I think remote consulting does challenge that.
Yeah, brilliant. I think some really good points there, Rob. And again, this is a discussion that's going to go. It's probably developed a lot since March, since it all
Yeah.
started. It's going to develop week by week, month by month going forward, especially as many more consults are done and much more experience is gained and common problems are found out. But I think it's been really useful, and thank you so much once again for your time and just looking through all the comments. Apologies we didn't get to all of the questions, there's a lot come through, but all the comments in terms of how useful this was it was clear to see that it's been of some value to people. So thank you so much, Rob, for your time. And any final comments from yourself before we close?
Well, no, thanks. It's been a real pleasure to join you. Sorry I couldn't see everybody in person, but that's maybe the doing things remotely. No, I think it's a tremendously exciting time to be going into general practice, and it's challenging. There's a lot going to change, but as I said, I think GPs by their nature are an entrepreneurial lot. And I think if you take the opportunity to use the emerging technologies and shape them, I think it could add to. It'll be different, but I think it could make the job really quite exciting and worthwhile.
Fantastic. Thank you so much, Rob. There's a couple of questions coming in saying, is this going to be recorded? Can we watch it back? Yes, we should be getting this on the website and also on our YouTube channel over the next day or two, so you can go back and watch any areas that you missed. I know some of you guys came in quite late. Just a quick recap about some of the ways that we can help you for your exams. A lot of you have now signed up to Arora Daily. We send a daily email with a quick bit of teaching from a video aspect. If that's something that you may be finding useful for your exams, you just head to the website. There's a bar at the top that says join Arora Daily. You can join onto that. And we do a lot of teaching passively through social media as well. I know a lot of you guys heard about this webinar through our various social media channels, but please do check those out if you're preparing for exams or if you're a GP trainee. Thank you so much, guys, for your time. Thank you, Rob, for all of your time as well. You've been super helpful. If we get any other questions that you have, please do send them in to us on email. And Rob, are you happy for us to send any?
Absolutely. Yeah. Keep in touch.